let's say we make the diagnosis, and the diagnosis is accurate. So you've got their attention because it's going to cost something to treat it. What are your goals? I mean, at some point, at any stage of this disease, what are we looking for?
Well, we're looking to manage this chronic disease. So when we employ anti-VEGF therapy, most people do so with monthly treatment. So we sit down and have a discussion with the patient and their family, and we initiate treatment. This tends to be monthly injections until the disease is inactive or stable. And then at that point, most people in the United States employ what's called a treat and extend strategy, where we try and lengthen out the treatment intervals in the absence of disease activity.
Okay, but let me be very specific.
Yeah.
In each stage of the disease, you've got to have some endpoint, something that you're looking for. Is it possible to halt the progression of this disease? Yeah. And is that what our goal is? Or are we actually looking to improve vision?
So the way I put this to patients is that we have a 90% chance, if we adequately treat you, of maintaining the vision that you have when I first find the wet disease or improving it. 10% of patients over 2 years will lose vision despite adequate and appropriate treatment.
Okay, but 90%, and this was a certain diagnosis of blindness, how long ago?
Well, the anti-VEGF era really started around the mid-2000s, and really
10, 15 years?
Yeah, so you're looking really, 10 to 12 years of having effective anti-VEGF agents that can really improve vision for a lot of patients. The best treatments that we had prior to that were just slowing the disease down and making you less worse.
I mean, I must tell you that when you take a look across the whole waterfront of medicine, this last 10 to 15 years has been dramatic in so many areas: heart disease, the statins, and now anti-VEGF. So,
well, I would argue that, if you take all of medicine, and certainly I'm biased, that this is one of the greatest innovations in medicine that we have in the last 20 years. We've talked about the economic impact, the impact that it can have on patients in their well-being and quality of life. It's amazing to be able to do this. It really is. I have to pinch myself sometimes and say, what we can do for you is amazing. My partner used to say that I was the minister that only did funerals. That's what he did when he treated wet AMD prior to this era. And the fact that we can offer these treatments is very exciting.
And restore vision is the other part.
Yeah.
You mentioned I can hold you in place or restore vision. Take it back a couple of clicks.
So I must admit, I have tempered excitement about this. I love the
Why is
era
that?
that we're in. VEGF blockade, it works really well. But it's not great, actually. If you look at actual ultimate visual acuity outcomes, you guys are seeing 20/20 right now, and you kind of like it. The successes that we're talking about are often not 20/20.
Yeah.
That's why it's important that Jared and I and the whole field continue to push forward, because we're doing pretty well with the VEGF blockade, but we got further to go, and those drugs are going to be expensive.
Well, look, again, everybody would like 2020.
Yep.
Somebody would like 2015. That would be very nice.
Yep.
But if I'm 2080, 20100, and you can bring me back toward 2020, I'm going to be pretty darn happy.
If you look at the percentages, though, again, 90% stay the same or get better. That's
Right.
not saying 90% are a home run getting a lot better. In fact, it's about a third get a lot better, which is pretty good, but that means that 2/3 are not getting a lot better. So we're doing really well. We need to do even better with what we have, but there is a future.
And the treatment burden is substantial. I mean, that's why we're here today, is the burden is substantial. And not just from an economic standpoint, but also from a visit standpoint. And so, Charlie mentions new drugs. I'm also optimistic that at some point we'll have ways of administering therapy that will last longer for the patients.
So,
And to get those percentages, you got to treat them aggressively.
Right.
And as Jared pointed out, the real world data that we have from around the world is we are grossly underdosing our patients for many reasons.
I want to get into why in just a minute. But I want to put two things together here and then sympathize for just a moment with the payer groups.
Yeah.
Which is, I heard, oh, it's great, but maybe not so great. And in order to even get not so great, there's a tremendous treatment burden. It's monthly, whatever, and there's drugs and they cost money. Is it worth it in terms of population dynamics, health dynamics from the payer perspective, if he says, I'm not so sure?
So absolutely worth it from a population health standpoint. If you're gonna look through the lens, to excuse the pun, if you're gonna look through the lens of population health,
I knew you would.
you are going to do much better with that population over the next 5 to 10 years if they have vision. Now, from a payer standpoint, is that sometimes our horizon is a little bit shorter than 5 to 10 years. And that's just because people can shift plans, they can go to another carrier, and the value that I get from treating aggressively or covering that aggressive treatment isn't something that's going to accrue to me. And that's part of the conversation we also need to have.
But you know what I heard you say that I really like? This is me, editorial, fair and balanced here. You said, when I treat, which means that you're taking some responsibility other than just paying for treatment, but you're concerned about the patient's well-being and concerned about your policies influencing patients' well-being. Is that how you see it?
So definitely, because I mean, even though obviously payers do not treat patients, if we don't cover something, it's the same as not allowing for the treatment. So we do have a responsibility, and I think again, we need to take a very fiduciary role here in terms of coverage of payments. But on the other hand, vision is an incredibly important thing, and so we need to figure out a way to do that.
So he's buying in as your partner.
Yeah, I'm willing to have any help that I can get in carrying this treatment burden, certainly.
Are you as committed as he to being the partner here?
Well, I am, and I was thinking about what what
You
Peter
heard the
was
same
saying.
thing I did, didn't you?
But really, I don't think that most payers will restrict or try to limit as you said, the marginal improvement.
Okay.
I just haven't seen that.
Well, I think I need to re-clarify here. I mean, there's sort of three outcomes, right? There's natural history, which is terrible for this disease. Patients cannot care for themselves, abominable. We need to end that.
Okay.
Then there's the outcome that you can get with maximal VEGF blockade, which is regular dosing indefinitely for most patients. But then there's what Jared and I are talking about, which is the future of research, where we can do even better than current treatments. But to get the second outcomes, you've got to treat them aggressively, and we're falling short for our patients, both as treating physicians and as payers. The patients are not coming back frequently enough, we are not giving enough treatments, and we're probably not using the right drugs.